Hello everyone in beautiful Sydney, and thank you for asking me to the Sydney Neuroscience Symposium. I'm speaking to you from very chilly Canada. My name is Dr. Dawn Timiansky, and I'm a nurse practitioner and the previous Chief Executive Officer of the Nurse Practitioners Association of Ontario and a previous board member of the World Federation of Neuroscience Nursing. Today I will be speaking with you about an innovative model of care delivery in the province of Ontario. So the goal of the talk today is to provide a brief overview of the healthcare delivery in Canada, to speak about how our healthcare system is funded, talk about some of the challenges and opportunities we face, speak about the nurse practitioner roles and the nurse practitioner-led clinic model of delivery, and the outcomes and future of this model. So let's get started. Canadian healthcare system is a mostly publicly funded service. It's built on the foundation of access to healthcare, which is based upon need, not on the ability to pay. Private care, such as discectomy, are against the Canadian Healthcare Act and are therefore not permitted. Services provided by this system, those that are considered essential, are considered free, which means there is no charge to the patient. For example, all hospital care, any diagnostic test, rehabilitation, physician fees, medications for those greater than 65, and travel costs for a patient or one family for specialty care not within a geographical location, and publicly funded healthcare long-term care homes are funded under this essential service. For low-income families and people over the age of 65, glasses, some dental work such as cleaning and fillings, and aids such as walkers and canes are also publicly funded. What is not covered under the system is cosmetic surgeries, alternative therapy such as acupuncture and non-essential care, and people in the country for less than 3 months. For those in the country visiting, such as if you're coming from Australia, essential care such as emergency surgery is provided free of charge, but be assured you will be asked about your travel insurance. So in order to understand a bit about how the system works, here is a picture of Canada. Canada is divided into provinces and territories, approximately 1/3 greater in landmass than the size of Australia. In terms of our funding models, it is divided into both federal or national monies and provincial expectations. The federal government is responsible for First Nations, military personnel, and all drug approvals, and pays about 30% of the total provincial healthcare bill. Each province or territory have a single-payer system. In Ontario, where I am, it is OHIP, or Ontario Health Insurance Plan. Each person in Ontario has an OHIP card, and this is presented for all essential services. Each province is responsible for the health of the provincial population, and each province pays approximately 70% of their healthcare costs. Each city, for example, Toronto, is responsible for public health, health promotion, and school immunization. About 1/3 of our total social spending supports the system, with approximately 70% of the monies coming from individual taxes, with about 1/3 of the system being paid private or out of pocket. This would be for things like drug coverage if you're under the age of 65, massage therapy, acupuncture, a rehab for greater than what is paid by the public system, etc. So let's talk a little bit about the limitations of the system. When you look at the province in which I live, if I were to drive from one end to the other as represented by this red line, and the province in which I live is this big yellow mass, it would take me 26 hours of straight driving without breaks to get from one end of the province to the other. This is something similar in distance to you driving from Sydney to Port Douglas. And if we look at the population density, and I'm sure that this is very similar to the interior of Australia, where most Australians live by the ocean, our population lives very close to the US border, and the north end of all provinces are very sparsely populated, with up to 0.4 people per kilometer in the majority of the provinces and less than that in rural areas. So as you can imagine, living in Northern Ontario is a challenge, mainly because no one wants to live on rock, but it is also difficult to get generalist healthcare providers far north and even more difficult to provide specialty care. Patients would have to drive significant distances for care. This led to poor health equity across the province. People believe that living north should not disqualify them from having timely access to primary or specialty care. There is a wealth of research on the outcomes on health equity. Often, people who live in the far north, their point of entry into the system is when people showed up in either their local emerge department or in a walk-in clinic. This leads to increased admissions to hospital because people would often wait until they got quite sick, increases length of stay in the hospital. Ultimately, though, this leads to poor community follow-up because there was no one in the community to follow them, and poor long-term health. People understood that timely access to a primary care provider leads to improved social and health outcomes. Currently in Ontario, about 8% of the population is noted to be without a primary care provider. The government, or the Ministry of Health in Ontario, was quite concerned about the number of people without this and began to look at how do they maximize health equity across the province and not just in Ontario. This led to centralization of the system with the improving development of telemedicine, centralization of critical care services across the province, and shifting of monies to developing community care more effectively. But the biggest shift, which we'll talk about in a little minute, is the undertaking of the expansion of the non-physician provider workforce. Significant work was undertaken around the non-physician provider workforce. There was a reopening and an expansion of the scope of practice for approximately 26 non-physician providers. Mainly, this included pharmacists, physiotherapies, nurse practitioners, and dietitians are just to name a few. Pharmacists now can reorder your prescriptions without a physician's order, can give you your flu shot, can teach you how to use ventilation, such as salbutamol. Physiotherapists can independently order x-rays. An NP practice expanded to that of approximately 80% of legislation as similar to a family physician. There was also a development and implementation of laws and regulatory changes that supported this practice change. Benefits were actually quite quick and obvious, including improved access to timely care, improved professionalism across groups because some people were now regulated and legislated, but there were drawbacks that were sort of predicted and non-predicted, including patient and system confusion. No one really knew who could do what now. No one knew that physiotherapists, for example, could order x-rays. There was role blurring. The hospitals didn't know how to make these rapid changes within the system because now they were legislated in. And there was unexpected professional hostility to increased scope and hostility to role poaching. And that is when one profession takes on the roles previously held by another profession, such as NPs now doing the work that was previously held only by medicine, such as ordering diagnostic imaging, including CTs and MRIs, and diagnostic tests, or even referring to specialists. So now that we know where nurse practitioner work is, and we know a little bit about them, let's talk a little bit about the role within Canada. It remains a relatively new role within the Canadian healthcare system, and we have around 6,000 licensed nurse practitioners, and we're graduating approximately maybe 1,000 more a year. I know one province in Quebec is expanding up to 2,000 roles within the next 2 years or so. Nurse practitioners are regulated by their College of Nurses. We are licensed, self-regulated, and title protected. So only a nurse practitioner is allowed to be called a nurse practitioner. We are now required to have a graduate degree in nursing. We work in a variety of settings, and each NP holds a particular license, that of pediatrics, adults, or primary care. This means that if I hold an adult license, I cannot manage children's health. But the majority of adult or pediatric specialists work within the acute care sector, such as a children's hospital or an adult surgical hospital. A small percentage of nurse practitioners are now moving into private practice, such as roving pediatric teams, cosmetic practice, and private consultation. The average salary of a nurse practitioner, depending upon your work, is around 100,000 to 160,000 Canadian dollars. And that is actually quite equivalent to your dollar because we are very close to par. And we are able to autonomously diagnose, order and interpret diagnostic tests, prescribe any and all medications, refer to specialty care, do specialty procedures such as LPs or lumbar drains for chronic pain. We can now admit and discharge from hospital independently. So admission, treatment, and discharge from hospital allows NPs in the rural communities to manage her community patient while they're in the hospital setting. NPs also are required to have hospital privileges. NPs can run independent clinics in the acute care sector, such as being the most responsible provider, and now are moving into private practice. So a combination of scope of practice and noted health inequity, a few NPs came up with actually quite a brilliant idea. There was an NP submission to the Ministry of Health for an innovative proposal to support targeted populations in an underserviced location. So for example, in a city called, or a town called Sudbury, was very underserviced with a significant proportion of clients or people within that town not having a primary care provider. So a couple of NPs put together this proposal, said, how about we open up a nurse practitioner-led clinic? It was a new primary care model where NPs were the sole primary care provider. The goal was to improve access in rural and remote locations and ultimately reduce system costs and improve outcomes because patients would be seeing them instead of going to the emerge department. The proposal was called the Nurse Practitioner-Led Clinics, and it actually started out as a pilot with one clinic and has now morphed into 26 clinics in the province. And there is a targeted of 25 new clinics coming within the next few years. What is a nurse practitioner-led clinic? So nurse practitioner-led clinics are funded as not-for-profit with direct funds coming from our Ministry of Health. It includes a community board of directors, so people within the community sit on the board, and is a highly inter-collaborative model of care delivery. They cost around $1 million to $1.5 million annually to operate, so the ministry provides the clinic with those funds. It is completely NP-led and managed. Each clinic registers between 2,500 and 9,000 clients, depending upon the collaborative care that is there. Each NP manages around 1,000 clients, 900 to 1,000 clients, and each NP is required to work to full scope of practice. And clinic staff often includes 4 to 5 nurse practitioners, registered nurses, registered practical nurses, social workers, a pharmacist is on staff, a midwife, and a physician consult. So note that there is no physician on staff in these clinics, and the physicians often work through satellite and are often only required when the nurse practitioner, it's beyond her scope of practice, or that she is unsure of the care required for the patient. And of course, you know that with any new healthcare model of delivery, there needed to be some evaluation. So what has come out after all of these years of these NPs working independently is that NPLCs seem to manage more complex patients as compared to their family physician groups. Extremely cost-effective model of delivery to underserviced communities. And when we look at some of the data, we do know that through ministry standards of what is expected by primary care, you know, the 7-day hospital discharge follow-up, the NPs see patients on average within 83% of 7 days, where the Ontario average is currently 34%. If we look at patient involvement of care, which is a foundation of NP practice, it includes 94% and 86% is considered the average. So we do know that NPLCs, for example, or NPs working within there and the collaborative model of care seem to hit above and beyond what is expected by the provincial marker and sometimes way above the provincial average. Though that 7-day discharge is kind of disconcerting if you work in other primary care models. So why do they seem to be highly successful? So communities and clients seem to love this model of care delivery because they provide much needed care to vulnerable populations. It applies a nursing lens to care delivery with a mixture of a medical model. We do describe NPs as being a perfect marriage between nursing and medicine. NPs have the legislative scope of practice within our province to work to the capacity of about 80% of a family doctor in terms of their scope. 3 to 4 NP salary, really in the province of Ontario, is equivalent to one family doctor. So that suggests that leading to NPLC models really caring for a larger number of clients within a vulnerable or underserviced area. NPs have community buy-in because the board of directors includes the community. And they have physician backup. So if a client issues that arise outside the NP scope of practice or an issue is above and beyond that of the NP's understanding. So when we look at some of the benefits, so what are we seeing or what is beginning to show? Well, the benefits have improved pop-up private NP practice because we know that they work and there is need out there. So for example, in the province, we have some pediatric nurse practitioners who have left the acute care sector and are working as pop-up private nurse practitioner pediatrics down in rural and remote areas where pediatricians do not exist. We do have, and moving forward in the development of government-funded nurse practitioner-led specialty clinics, such as specialty clinics of mental health and addictions, and neurology clinic, and a pediatrics clinic, for example. And the development of NP-led clinics in other provinces, such as the province of Quebec, which is hoping to quadruple their number of NPs within the next 4 or 5 years. What do we continue to struggle with in some of the drawbacks or some of the limitations of the model? We still have significant physician resistance to NPs as primary care providers. And this is historical and this is slow and steady. It's like chipping away at an iceberg. It will come, but it is slow and steady. There remains some community resistance to non-physician providers because the public isn't quite sure of what we do and they're not sure if they should still be seeing a physician. And there currently is no source for communities to seek funding to develop nurse practitioner-led clinics with the Ministry of Health. So if a community likes the model and they consider themselves to be underserviced and the politicians are keen to do it, they cannot apply right now to the Ministry of Health to open up a clinic and get money from the government for that. And we are actually working on that as we speak. So you're probably maybe sitting in your chair after having lunch or coffee and thinking, wow, this sounds like a great idea. Independent clinic, manage vulnerable populations, especially I would assume in the rural and remote areas of Australia. And so what do you need to consider if you're thinking this through? Okay, you need to find a community that is considered underserviced by the politicians. Okay, rural and remote is best. And look to see if you have any government documents to support this, like health statistics. If you go to a community and you say, wow, there's no primary care provider here, so I think that it would be a great place, and you write up a business proposal, but the government doesn't think it's underserviced, then you're not going to get anywhere. So you have to look and see if these documents exist. The business proposal that showcases system cost reduction, such as hospital care access, such as the need to go to a walk-in clinic, and maybe improved health outcomes. This really depends upon the government of the day or the flavor of the month. So if the government is currently interested in cost reduction or keeping patients out of the hospital, you might be able to apply this. But if they're looking at building infrastructure and roads or things like that, your proposal isn't going to be timely at that time. You need to have community leadership. So speak with a mayor or someone high up to get buy-in to this model of care. Do your diligence around data collection or looking at the research to see what's out there. You need to have physician buy-in. I probably cannot stress this enough because a lot of the angst that goes with physicians, resistance to nurse practitioners, because they really don't understand, certainly in Ontario, what exactly an NP does and that we are not taking over the role of physicians. We are not considered physician replacements. But physicians get angry or anxious when they believe nurse practitioners are encroaching on their territory that was previously held specifically by medicine. What I would suggest you do is really consider having 1 or 2 physicians on your planning committee and looking at how to integrate primary care delivery into rural and remote with the nurse practitioner as a primary lead. You need to have political will. Okay, when you're talking to anybody, the mayor or whoever runs the town, really think about approaching them when it's a re-election or an election, using this as an election platform, because people will say, wow, if Mr. Smith or Mrs. Smith can open up a clinic here for healthcare delivery, I'm going to vote for them because I don't have a healthcare provider. You also need a competent and confident NP workforce in skills and community networking. This isn't the time when brand new graduate NPs come out and decide they're going to move to a rural area and open up an NP clinic. They need to have very strong clinical skills because if you show up and you're not confident or competent, there is less ability for people to appreciate the role. People get a bit nervous about there isn't a lot of confidence in the NP, and then you stop going and the model will fail. Okay. Be prepared that you'll have to collect data to show the outcomes, that you're cost effective, that you improve client outcomes, that you meet the benchmarks set by your territory or state, so that you understand that these are the markers that they have expectations to, and you need to be able to collect those. You need a structure that will support a clinic. So you need to make sure there's a building. You need to be able to hire support staff, direct support staff such as nurses or administrative staff, but people like social worker, pharmacists, if it's rural enough, can be virtual if you cannot get them to rural and remote settings. And finally, you need to start small and sell yourself as a different provider. So in NPLC, we are not considered physician replacements, but see how you can meet the needs of a community within the district that you're thinking. So in summary, nurse practitioner clinics are an effective model for care delivery in an underserviced and vulnerable population. It allows the NP role to be showcased as having equal or greater health outcomes as compared to other providers providing similar care. It captures an interdisciplinary model of care delivery, which is incredibly important and provides 360-degree care for your client, and it improves health equity in rural and remote geographical areas. So thank you very much for allowing me to talk at the conference today, and enjoy the rest of your day. Bye-bye.